Hello and welcome. If the D545 OA exam has been on your mind and you're wondering how to approach it, then you're in the right place. Our website has D545 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from healthcare leadership, organizational models, power dynamics, care models, healthcare management. So let's get started.
Question 1. A hospital faces a sudden viral outbreak that requires immediate quarantine protocols and strict adherence to infection control measures across every department. Which leadership style would most effectively guide the rapid response needed during this emergency to protect both staff and patients from harm? Your options are A. Autocratic leadership style, B. Laissez-faire leadership style, C. Democratic leadership style, D. Servant leadership style. Which one is it? Pause the video if you need more time. The correct answer is A. Autocratic leadership style. A is correct because autocratic leadership enables rapid centralized decision making and strict enforcement of infection control guidelines across departments, which is essential during crises that demand immediate unified action to contain viral spread effectively. B is wrong because laissez-faire leadership offers minimal guidance and allows subordinates to work independently, which creates dangerous delays during outbreaks when immediate authoritative directives and tight control are needed to contain infections. C is wrong because democratic leadership emphasizes shared decision-making and collaborative consultation among staff members, but this extended process consumes valuable time during outbreaks when infection control demands swift directives rather than group discussion. D is wrong because servant leadership prioritizes meeting employee and patient needs through empathy and support first, but this relationship-focused approach lacks the authoritative speed required to enforce quarantine protocols during fast-moving viral outbreaks. Autocratic leadership concentrates all decision-making in a single leader who directs, and subordinates execute. Understanding why this style exists and when it fits requires looking at the conditions that make centralized authority valuable. The mechanism rests on three features. Authority sits with one person, so accountability is unambiguous. Communication runs in one direction, keeping the message consistent. And enforcement is immediate. No consensus is needed before acting. Picture a regional medical center where a novel respiratory virus is confirmed. The chief medical officer activates the emergency plan, suspends elective procedures, mandates fit testing, and assigns isolation protocols by memo, all within the hour. No committee convenes. Autocratic leadership is most often confused with democratic and transactional styles. Democratic leadership shares the decision, the opposite of what a fast outbreak allows. Transactional leadership trades rewards for compliance rather than issuing direct commands. Autocratic authority does not bargain and does not consult. The trap is assuming that because autocratic control works in an emergency, it works everywhere. When the threat is acute and unified action matters more than buy-in, centralized authority is the right fit, but applying it to daily operations corrodes morale over time. Question 2. A community hospital wants to implement innovative patient care program and inspire staff to embrace organizational change. The CEO seeks a leadership approach that motivates employees through vision and personal growth rather than financial rewards alone. Which style best fits this goal? Your options are A. Transactional leadership approach, B. Bureaucratic leadership approach, C. Transformational leadership approach, D. Autocratic leadership approach. Take a second. Which answer would you pick? The correct answer is C. Transformational leadership approach. C is correct because transformational leadership inspires innovation and motivates employees through a compelling vision, individualized consideration, and intellectual stimulation, which aligns perfectly with driving meaningful organizational change and encouraging personal growth across departments. A is wrong because transactional leadership relies on contingent rewards and punishments to drive compliance, which contradicts the hospital's goal of inspiring employees through vision and personal growth rather than financial exchanges alone. B is wrong because bureaucratic leadership emphasizes strict rules, hierarchy, and consistency over innovation, which limits creativity and change, making it poorly suited for launching innovative patient care programs that require adaptive employee engagement. D is wrong because autocratic leadership centralizes decisions without input and discourages creativity, which contradicts the transformational goal of motivating staff through shared vision and empowering them to contribute fresh ideas for innovation. Transformational leadership is about raising people's sights, inspiring them to commit to a shared vision and grow their own capabilities, rather than simply exchanging effort for reward. The concept was first drawn by James McGregor Burns in the late 1920s, then built into a measurable framework by Bernard Bass. Bass identified 4 behaviors that together produce the effect. Idealized influence means the leader models the values they ask of others. Inspirational motivation communicates a vision that gives work meaning. Intellectual stimulation invites people to question assumptions. And individualized consideration develops each person as a distinct talent. It helps to contrast transformational leadership with the styles it's most often confused with. Transactional leadership manages the existing system through contingent rewards and corrective penalties. Autocratic leadership centralizes decisions and discourages input, the opposite of intellectual stimulation. Transformational leadership is defined by that upward, meaning-driven pull. Transformational leadership can coexist with bonuses, but its real engine is meaning, growth, and identification with a shared purpose. When a scenario stresses that staff are inspired to internalize a vision rather than chasing financial incentives, transformational leadership is the answer. Question 3. A free clinic serves homeless patients and refugees with complex medical and social needs. The director wants to prioritize the well-being of both staff and vulnerable patients while fostering compassionate care delivery. Which leadership style best supports this mission-driven environment? Your options are A. Machiavellian leadership style, B. Transactional leadership style, C. Laissez-faire leadership style, D. Servant leadership style. Before I reveal it, which one do you think is right? The correct answer is D. Servant leadership style. D is correct because servant leadership focuses on meeting the needs of others, especially vulnerable populations, by prioritizing employee and patient well-being through empathy, support, and mission-driven care, which matches the clinic's purpose precisely. A is wrong because Machiavellian leadership prioritizes efficiency and control, sometimes at the cost of morale, and uses manipulation over empathy, which conflicts sharply with the compassionate, mission-driven approach needed when serving vulnerable populations. B is wrong because transactional leadership motivates through rewards and punishments for compliance, but this exchange-based approach fails to cultivate the empathy and mission-driven care required when serving homeless patients and refugees with complex needs. C is wrong because laissez-faire leadership provides minimal guidance and oversight, which risks inconsistent care for vulnerable patients who need structured, compassionate support and coordinated services to navigate complex medical and social challenges effectively. Servant leadership inverts the usual leadership hierarchy. The leader's first commitment is to the growth and well-being of the people being led, not to authority or status. Influence is earned by helping others develop and succeed. The model operates through a specific cluster of behaviors. Servant leaders listen before directing, practice empathy towards staff and patients alike, build community inside the team, and deliberately develop people rather than simply extracting performance from them. Robert Greenleaf, who named the concept in 1970, proposed a defining test. Do those served grow as people, becoming healthier, wiser, more autonomous, and more likely themselves to serve? The leader acts as a steward, holding the organization in trust for the people it exists to help. The critical distinction is between serving people and controlling them. Servant leadership meets needs and builds capacity, while Machiavellian leadership manipulates and extracts compliance through fear. Opposite means toward the same claimed goal. Whenever a scenario foregrounds empathy, staff well-being, patient dignity, and a mission-driven setting, servant leadership is the fit. The defining move is always placing the needs of others first, active, not passive, and never about control. Question 4. A nurse manager oversees a mixed team of new graduates and experienced nurses with varying confidence levels. She adjusts her approach based on each nurse's skill and maturity, from giving direct instructions to delegating tasks. Which theory describes this flexible approach? Your options are A. Path goal theory, B. Situational leadership theory, C. Fiedler contingency model, D. Transformational leadership theory. What's your answer? Commit to one before I continue. The correct answer is B. Situational leadership theory. B is correct because Hersey and Blanchard's situational leadership theory emphasizes adapting leadership styles, from telling to delegating, based on employees' skill levels and maturity, which matches how the manager adjusts her approach with individual nurses. A is wrong because path goal theory by Robert House focuses on leaders clearing paths to goals and removing obstacles to motivate subordinates, rather than specifically adjusting styles based on employee maturity and experience levels. C is wrong because Fiedler's contingency model argues a leader's style is innate and unchangeable. So leaders should be matched to situations, which contradicts the adaptive approach the nurse manager is clearly demonstrating here. D is wrong because transformational leadership theory focuses on inspiring change through vision, empathy, and idealized influence, not on adjusting directive versus delegative styles based on each subordinate's specific experience level and skill maturity. Situational leadership theory, developed by Paul Hersey and Ken Blanchard, argues there is no single best leadership style, only the right style for a particular person at a particular moment. Flexibility is the entire point. The model pairs two dimensions, directive behavior and supportive behavior, into 4 styles. Telling gives close instruction to beginners. Selling adds encouragement. Participating shares decision-making. And delegating hands off full authority to skilled, confident followers. It is easy to confuse this with related theories. Fiedler's contingency model says a leader's style is fixed, so you place the leader in a fitting situation. Path goal theory focuses on clearing obstacles to motivate followers. Trait theory treats leadership as a stable personality. Situational leadership stands apart because the same leader deliberately changes style. When you see signal words like adapt, adjust, readiness, or skill level, and a leader changing approach for each individual, that is situational leadership. The manager changes to fit the follower, not the other way around. Question 5. A hospital administrator prioritizes operational efficiency and cost reduction above all else, using fear of termination and strict penalties to ensure compliance. Employee morale has declined significantly, but financial targets are consistently met. Which leadership approach is being demonstrated here? Your options are A. Machiavellian leadership, B. Democratic leadership, C. Servant leadership, D. Authentic leadership. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Machiavellian leadership. A is correct because Machiavellian leadership prioritizes efficiency and control through manipulation, fear, and punishment, often sacrificing employee morale for organizational gains, which directly matches the administrator's approach of using fear to enforce compliance. B is wrong because democratic leadership encourages collaborative decision-making and values employee input, which would typically improve morale rather than decrease it, making the style fundamentally incompatible with the fear-based approach described here. C is wrong because servant leadership places the well-being of employees and others first, building trust and support, which is the direct opposite of using fear and penalties to enforce operational efficiency at staff expense. D is wrong because authentic leadership involves being honest about conditions and maintaining open, transparent communication, which does not align with relying on fear, intimidation, and strict penalties to achieve organizational cost reduction targets. Machiavellian leadership is built on a single premise: results come first, and almost anything is acceptable in pursuit of them. Named for Renaissance writer Niccolo Machiavelli, this style holds that the ends can justify the means. The mechanism is control through pressure. These leaders monitor closely, withhold or grant information strategically, apply fear of consequences to secure compliance, and keep decision-making tightly held. People are viewed not as individuals but as levers for producing a desired result. Targets get met and costs get contained, which can look impressive on a financial report. But the hidden expense shows up in eroded trust, disengagement, and turnover among staff who feel used rather than valued. It helps to contrast the style with its opposites. Servant leadership puts people first. Authentic leadership runs on transparency. Democratic leadership invites participation. Machiavellian leadership is defined by its willingness to sacrifice workforce well-being to hit the goal. When a leader consistently pairs strong results with intimidation, information control, and a disregard for people, that is the Machiavellian orientation. The signal is not just hitting targets, it is how those targets are hit. Question 6. A hospital department manager announces that any employee who exceeds quarterly performance goals will receive a promotion, public recognition at the next staff meeting, and an increase in salary. Which form of power is the manager actively exercising through these incentives? Your options are A. Coercive power, B. Legitimate power, C. Reward power, D. Referent power. Which would you go with? Lock it in before the reveal. The correct answer is C. Reward power. C is correct because reward power influences others by offering incentives such as promotions, recognition, and salary increases, which directly matches the manager's strategy of motivating employees through tangible and intangible positive reinforcements tied to goals. A is wrong because coercive power relies on threats of punishment or negative consequences to influence behavior, which is the opposite of offering promotions and recognition as positive incentives for exceeding performance goals. B is wrong because legitimate power derives from formal position or authority within the organization, not from incentives. So while the manager holds legitimate power, the act of offering rewards specifically demonstrates reward power. D is wrong because referent power stems from admiration and respect that cause others to emulate a leader, not from tangible incentives like promotions and salary increases, which are clearly reward-based motivators being applied. Reward power is one of 5 bases of social power identified by French and Raven in 1959. Their framework showed that a leader's influence doesn't come from a single source. It flows through several distinct channels, each operating differently. French and Raven mapped 5 bases: rewards, coercive, legitimate, referent, and expert. Reward power is unique because it operates through positive exchange. The leader offers something desirable in return for the behavior they seek. The mechanism is conditional. Reward power only works when the leader genuinely controls rewards the employee values, and when the employee believes those rewards will actually follow performance. Rewards can be tangible, like salary and promotions, or intangible, like public praise and recognition. The key exam distinction is separating reward power from coercive, legitimate, and referent power. When a scenario describes a leader motivating through desirable consequences, they can deliver a raise, a promotion, a preferred schedule. That is reward power at work, not positional authority. Whenever a STEM describes motivation through incentives a leader controls, bonuses, recognition, choice assignments, reward power is the concept at work. The influence lives entirely in the leader's ability to give people what they want. Question 7. A clinic supervisor issues formal warnings and threatens suspension without pay for staff who fail to document patient encounters correctly. Employees comply primarily out of fear of disciplinary action rather than genuine agreement. Which form of power is being used here? Your options are A. Expert power, B. Coercive power, C. Reward power, D. Referent power. Don't overthink it. Which one feels right? The correct answer is B. Coercive power. B is correct because coercive power uses threats of punishment or negative consequences to influence behavior, which directly matches the supervisor's approach of issuing warnings and threatening suspension to force documentation compliance from reluctant staff members. A is wrong because expert power derives from specialized knowledge or skill that others seek to follow, not from threats of disciplinary action, making this the wrong classification for fear-based compliance enforcement tactics. C is wrong because reward power influences through positive incentives such as bonuses, praise, or promotions, which is the opposite of the punishment-based approach used by the supervisor to enforce documentation standards here. D is wrong because referent power is built on admiration and respect that inspires voluntary compliance, which contradicts the fear-driven obedience described, where employees follow rules only to avoid negative disciplinary consequences. Coercive power is the ability to influence behavior through the threat of punishment. It is one of the 5 bases of power identified by French and Raven in 1959, and it is the oldest, bluntest instrument in any leader's toolkit. The mechanism depends on 2 things: a credible threat and active monitoring. The employee must believe the punishment is real and that the leader will notice non-compliance. This is why coercion tends to require surveillance. The behavior persists only while someone is watching. Leaders exercising coercive power can draw on a range of penalties: reprimands, suspensions, demotions, undesirable assignments, or termination. People comply not because they agree, but because they want to avoid these consequences. It helps to contrast coercive power with its neighbors. Reward power pulls people with positive incentives. Referent power earns voluntary followership through admiration. Coercive power pushes through fear, and unlike the others, the compliance it produces is shallow and disappears the moment oversight relaxes. The signal to look for is avoidance of a negative outcome, when staff follow a rule only to escape punishment, not because they believe in it. Coercive power is the concept being tested. Resentment accumulates beneath the obedience, and old habits return the moment no one is watching. Question 8. Medical residents consistently seek out a senior attending physician for advice because they deeply admire her ethical conduct, clinical wisdom, and warmth toward patients. She holds no formal authority over them, yet they follow her example naturally. Which power type is this? Your options are A. Legitimate power, B. Coercive power, C. Expert power, D. Referent power. Got a guess? Lock it in. The correct answer is D. Referent power. D is correct because referent power is built on admiration, respect, and relational influence that leads others to voluntarily emulate the person, which matches how residents follow the attending physician's example without any formal authority. A is wrong because legitimate power comes from an official position or title that grants authority within the hierarchy, but the scenario specifies she holds no formal authority over the residents who follow her. B is wrong because coercive power depends on threats and negative consequences to force compliance, which contradicts the voluntary admiration-based following described, where residents seek her out freely rather than out of fear. C is wrong because expert power is closely related but stems specifically from specialized knowledge and technical expertise, while referent power captures the broader admiration for her character, ethics, and warmth in the scenario. Referent power is the most personal of the 5 bases of social influence identified by French and Raven in 1959. Unlike other power sources, it flows entirely from who a person is rather than any title, skill, or authority they hold. French and Raven named 5 bases of power: reward, coercive, legitimate, expert, and referent. The first 4 all rely on external resources or position. Referent power is the 5th, and it stands apart because it requires none of those things. The mechanism runs through identification. When followers admire someone's ethics, character, and warmth, they internalize that person's example and voluntarily adjust their own behavior to match, no monitoring or enforcement needed. The most tested distinction is between referent and expert power. Expert power is admiration for what a person knows. Referent power is admiration for who a person is, their whole character, not just a skill. Legitimate power is different still, rooted in a formal title rather than any personal quality. When a scenario describes voluntary followership, people emulating a role model, looking up to someone's ethics, or following without any formal authority involved, that is the hallmark of referent power every time. Question 9. A hospital recently hired a researcher who holds a doctorate in infectious disease epidemiology. Colleagues and administrators frequently consult her before making pandemic preparedness decisions because of her deep technical knowledge. Which form of power is she primarily exercising here? Your options are A. Expert power, B. Reward power, C. Legitimate power, D. Coercive power. Which one is it? Pause the video if you need more time. The correct answer is A. Expert power. A is correct because expert power stems from specialized knowledge, technical skill, or advanced expertise that others seek out for guidance, which precisely describes how the researcher influences pandemic preparedness decisions through her doctorate-level knowledge and training. B is wrong because reward power influences behavior through incentives such as bonuses or recognition, but the researcher's influence comes from her specialized knowledge, rather than from her ability to offer tangible or intangible rewards. C is wrong because legitimate power arises from an official title or hierarchical position, but the scenario highlights her being consulted for knowledge and expertise rather than because she occupies a specific authoritative formal role. D is wrong because coercive power relies on fear of punishment and negative consequences, which does not apply since colleagues voluntarily seek her expertise, rather than following her guidance to avoid disciplinary or negative outcomes. Expert power is influence that comes from specialized knowledge and demonstrated mastery, not from rank, title, or formal position. It's one of the 6 bases in the French and Raven framework, first described in Nine Amfitan, and it's grown increasingly important as work has become more technical and knowledge-driven. Picture a hospital where administrators and senior physicians consult a researcher before making critical decisions, not because she outranks them, but because her command of the science is unmatched. Her influence flows entirely from what she knows, not from where she sits on an org chart. Expert power operates only when others believe the person genuinely possesses the needed knowledge and when that knowledge applies to the decision at hand. A specialist consulted outside her field carries little of it. Unlike coercive or reward power, expert influence requires no incentives. People come willingly because they want the benefit of the expertise. The key distinction is knowing versus ranking. Legitimate power flows from an official role, reward power motivates through incentives, and coercive power compels through fear. Expert power is isolated by one feature. People follow because of what the person knows, not because the hierarchy requires it. When a scenario describes someone constantly consulted for guidance despite holding no commanding position, the lever is the knowledge itself. Signal words like specialized expertise, technical skill, and sought out for advice all point to expert power at work. Question 10. A newly appointed hospital CEO assumes authority over all department directors, clinical staff, and support services through her executive position. Staff follow her directives primarily because of the formal authority granted by her role. Which type of power is she exercising? Your options are A. Referent power, B. Expert power, C. Legitimate power, D. Coercive power. Take a second. Which answer would you pick? The correct answer is C. Legitimate power. C is correct because legitimate power comes from an individual's formal position or authority within an organization, which matches how the CEO directs staff based on her executive role rather than expertise or personal admiration from others. A is wrong because referent power is built on admiration, respect, and personal relationships that inspire voluntary following. But the scenario specifies staff comply because of her formal authority rather than personal admiration. B is wrong because expert power flows from specialized knowledge and technical skill that others seek for guidance, but the scenario focuses on her executive position and title rather than her specific clinical or technical expertise. D is wrong because coercive power relies on fear of punishment and disciplinary threats to force compliance, which differs from legitimate authority granted by a formal title where staff follow directives based on organizational hierarchy. Legitimate power is one of the foundational sources of influence in organizations. It comes entirely from holding a formal position, not from personal qualities or specialized knowledge. Understanding what makes it unique helps clarify how authority actually flows through a hierarchy. Legitimate power has 4 defining features. It is attached to the office, not the person. It transfers automatically to whoever occupies the role. It is bounded by the scope of that position. Directives outside the role's domain lose their force. And it functions only while employees recognize the structure as rightful. The clearest proof of legitimate power is what happens when a leader leaves. The authority stays with the chair and passes to the successor. A newly appointed executive can direct entire departments from day one, before earning expertise or rapport, simply because the position carries the recognized right to lead. The French and Raven framework named legitimate power specifically to separate positional authority from other sources. Expert power flows from specialized knowledge. Referent power draws on personal admiration. Coercive power compels through fear of punishment. Legitimate power needs none of these, only the office itself. When an exam scenario stresses that staff comply because of someone's formal role, using phrases like formal authority, official title, or by virtue of position, legitimate power is the concept under test. The influence belongs to the position, not the person. Question 11. A regional health system continuously monitors changing community demographics, new regulations, emerging technologies, and competitor moves in order to adapt its services. The leadership views the organization as constantly interacting with external forces. Which organizational model best describes this approach? Your options are A. Rational goal model, B. Open systems model, C. Internal process model, D. Human relations model. Before I reveal it, which one do you think is right? The correct answer is B. Open systems model. B is correct because the open systems model views patient care and operations as an adaptive system, continuously interacting with external factors through inputs, throughputs, and outputs, which matches the health system's responsive approach to environmental changes. A is wrong because the rational goal model emphasizes productivity, efficiency, and structured goal setting internally, rather than focusing on continuous adaptation to external environmental changes such as shifting demographics, regulations, and competitive market pressures. C is wrong because the internal process model focuses on control, stability, documentation, and accountability within the organization, which contrasts with the external adaptive orientation required to respond to community demographics and regulatory changes. D is wrong because the human relations model emphasizes employee engagement, morale, and participatory decision-making internally, rather than the external scanning of demographics, regulations, and technology that defines continuous adaptation to environmental shifts. The open systems model treats an organization like a living organism, one that cannot survive in isolation. It must constantly exchange resources and information with the world around it to stay alive and relevant. The mechanism has three parts: inputs, the staff, funding, and patients drawn in; throughputs, the care processes that convert those inputs; and outputs, health outcomes and community reputation. Feedback loops then carry signals about those outputs back into the system, driving adaptation. It helps to contrast the open systems model with its three siblings. The rational goal model focuses inward on productivity, the internal process model on stability, and the human relations model on morale. Only the open systems model turns the gaze outward toward the environment. On exam questions, certain signal words flag the open systems model. Look for language about adapting to the external environment, scanning demographics, regulations, or competitors, and continuously adjusting services. The emphasis on outside forces and responsiveness is the decisive tell. The defining trait of the open systems model is permeability. The boundary between organization and environment is open by design. Leadership's job is not internal tidiness, but faster adaptation than conditions change. Question 12. A surgical center implements strict productivity metrics, standardized procedures, and efficiency targets to maximize patient throughput while controlling operational costs. Leadership emphasizes planning, measurable goals, and tight control over outcomes at every stage. Which organizational model best reflects this management philosophy? Your options are A. Rational goal model, B. Human relations model. C. Open systems model. D. Competing values framework. What's your answer? Commit to one before I continue. The correct answer is A. Rational goal model. A is correct because the rational goal model prioritizes structured goal setting, planning, productivity, and efficiency to achieve measurable outcomes, which directly matches the surgical center's focus on throughput, cost control, and clearly defined operational metrics. B is wrong because the human relations model prioritizes employee morale, engagement, and participatory decision-making over strict productivity metrics, which contrast sharply with the efficiency-driven, throughput-focused approach described at the surgical center here. C is wrong because the open systems model emphasizes adaptability and continuous interaction with external environments through inputs and outputs, which differs from the internal productivity and efficiency focus that characterizes the surgical center's philosophy. D is wrong because the competing values framework is a broader assessment tool balancing adaptability, flexibility, stability, and control across 4 quadrants, rather than a single philosophy centered only on productivity and efficiency targets. The rational goal model defines organizational effectiveness as the disciplined pursuit of productivity and measurable results. It traces back to Frederick Taylor's scientific management, which recast work as something to be measured, standardized, and optimized for maximum efficiency. The mechanism centers on planning and goal attainment under tight control. Leaders set specific targets, allocate resources efficiently, standardize procedures to reduce variation, and judge success strictly by whether those targets were met. When a scenario emphasizes productivity, efficiency, throughput, measurable goals, tight control, or planning, the rational goal model is the framework being described. In healthcare, this surfaces wherever cost per case and standardized procedures dominate the conversation. The 2 models most often confused with this one are the human relations model and the open systems model. Human relations prizes employee morale and participation, while open systems looks outward and adapts to the environment, whereas the rational goal model concentrates solely on hitting its own measurable internal targets. The key distinction exam writers test is straightforward. The rational goal model is about getting measurable things done efficiently and at low cost. Morale and environmental scanning belong elsewhere. Here, disciplined output is everything. Question 13. A community hospital invests heavily in employee engagement surveys, peer recognition programs, team building retreats, and participatory decision-making forums. Leadership believes that staff morale and collaborative input drive organizational success more than strict efficiency controls. Which model does this reflect? Your options are A. Internal process model, B. Open systems model, C. Rational goal model, D. Human relations model. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Human relations model. D is correct because the human relations model emphasizes employee engagement, morale, teamwork, and participatory decision-making as drivers of organizational effectiveness, which precisely matches the hospital's investment in staff surveys, recognition programs, and collaborative forums. A is wrong because the internal process model focuses on documentation, accountability, structure, and stability rather than on employee morale and engagement, which makes it a poor fit for the hospital's participatory and relational approach. B is wrong because the open systems model centers on adapting to external environmental factors through continuous interaction, which differs from the internally focused employee engagement and morale-driven approach described in this community hospital scenario. C is wrong because the rational goal model prioritizes efficiency, productivity, and structured goal attainment through tight controls, which conflicts directly with the hospital's collaborative, morale-focused philosophy emphasizing participatory decision-making over strict performance metrics. The human relations model holds that organizational effectiveness flows from the people inside it, their morale, engagement, and sense of belonging, rather than squeezing productivity through control. This framework treats a healthy human environment as the engine of performance. The model traces back to the Hawthorne studies of the 1920s and 30s, where researchers found that worker output rose simply because employees felt noticed and involved. That discovery shattered the purely mechanical view of management and launched serious attention to motivation, group dynamics, and job satisfaction. The model works through three reinforcing forces: participation, recognition, and relationship. Leaders invest in morale through engagement surveys, peer recognition programs, team building, and shared decision-making, trusting that committed people deliver better results. The critical distinction exam writers test is this contrast. Internal process prizes stability and documentation. Rational goal prizes measurable output. But human relations flips that priority, treating the engagement and well-being of people as the foundation everything else rests on. When a scenario foregrounds morale, engagement, teamwork, participation, or recognition, and frames investing in people as the path to success, the human relations model is the framework in play. Question 14. A large teaching hospital emphasizes detailed documentation, standardized protocols, clear accountability chains, and consistent reporting across all units. Leadership values stability, precise record keeping, and predictable processes over rapid change or adaptation. Which organizational model best captures this operational philosophy? Your options are A. Human relations model, B. Open systems model, C. Internal process model, D. Rational goal model. Which would you go with? Lock it in before the reveal. The correct answer is C. Internal process model. C is correct because the internal process model emphasizes accountability, structure, efficiency, and thorough documentation to ensure stability and predictability, which matches the teaching hospital's reliance on standardized protocols, detailed records, and consistent reporting practices across units. A is wrong because the human relations model centers on employee engagement and morale through participatory practices rather than on documentation, accountability, and stability controls that define the teaching hospital's process-driven operational philosophy. B is wrong because the open systems model emphasizes continuous external adaptation and environmental responsiveness, which differs from the internal stability, predictability, and documentation focus described at this teaching hospital in the given scenario. D is wrong because the rational goal model focuses on productivity, efficiency targets, and structured goal attainment, while the internal process model specifically addresses the stability, accountability, and documentation emphasis described in the given scenario. The internal process model treats organizational effectiveness as a product of structure, control, and reliable procedure. The core idea is simple. Govern your own processes well and the outcomes will be predictable every time. Max Weber's theory of bureaucracy, developed in the early 20th century, provided the intellectual foundation. Before formal procedure, organizations ran on favoritism and improvisation. Weber argued that written rules, hierarchy, and record keeping were the most reliable way to run a large organization fairly and consistently. When a scenario emphasizes documentation, standardized protocols, defined accountability, and predictable processes, the internal process model is the framework being described. The orientation is internal and control focused. The organization watches its own machinery, not the external environment. The two models most often confused with internal process are human relations and rational goal. Human relations also looks inward but prizes morale and participation over procedure. Rational goal shares the control orientation but targets productivity and measurable output. Internal process alone makes consistent, well-governed process its central aim. Whenever stability and record keeping are the stated priority, not engagement, not output volume, and thus you are looking at the internal process model. Order is the goal, and that distinction is what exam writers are testing. Question 15. A healthcare consultant assesses an organization by examining how well it balances adaptability, flexibility, stability, and control across 4 distinct quadrants. She uses this assessment to evaluate organizational culture and effectiveness. Which framework is she applying in her analysis? Your options are A. Pathgall framework, B. Competing values framework, C. Affective events theory, D. Tuckman's group model. Don't overthink it. Which one feels right? The correct answer is B. Competing values framework. B is correct because the competing values framework was developed by Quinn and Cameron, assesses organizational effectiveness across 4 quadrants balancing adaptability, flexibility, stability, and control, which matches the consultant's approach to evaluating culture and organizational performance. A is wrong because Pathgall framework is a leadership theory by Robert Howson, focused on how leaders clear paths and remove obstacles for subordinates, not a model for assessing organizational culture across competing value quadrants. C is wrong because affective events theory explains how workplace events trigger emotional reactions that influence job performance and attitudes, rather than providing a framework for evaluating organizational effectiveness across culture and structural dimensions. D is wrong because Tuckman's group model describes the 5 stages of team development from forming through adjourning, which focuses on team dynamics rather than assessing broader organizational culture across competing values and quadrants. The competing values framework is a diagnostic tool for mapping organizational culture and effectiveness. It doesn't describe one ideal culture, it holds all possible cultures on a single map, revealing how an organization balances opposing values. Crossing 2 tensions, internal versus external focus, and flexibility versus control, produces 4 quadrants. Each quadrant represents a distinct model of organizational effectiveness, and every organization sits somewhere across all 4 simultaneously. The human relations model emphasizes collaboration and people. The open systems model emphasizes creativity and adaptation. The rational goal model focuses on results and productivity. The internal process model focuses on stability and procedure. The key distinction exam writers test is the difference between the whole framework and any single quadrant inside it. When a scenario describes assessing an organization across adaptability, control, flexibility, and stability all at once, that is the competing values framework at work, not any one of its models. Quinn and Rohrbaugh built this framework because competing definitions of effectiveness all turned out to be real, just pulling in different directions. The tool's power is showing the full picture at once, exposing what an organization overemphasizes and what it neglects. Question 16. A health system is transitioning its payment structure so that providers are reimbursed based on patient outcomes, quality metrics, and cost effectiveness rather than the number of services performed. Which healthcare delivery model best describes this approach adopted by the system? Your options are A. Value-based care model, B. Fee-for-service model, C. Bureaucraticare model, D. Biomedical care model. Got a guess? Lock it in. The correct answer is A. Value-based care model. A is correct because value-based care reimburses providers based on patient outcomes, quality, and cost effectiveness rather than service volume, which directly matches the health system's new payment structure, prioritizing measurable results over quantity, metrics, and service counts. B is wrong because fee-for-service pays providers based on the number and type of services delivered, which is the opposite of the outcomes-based reimbursement structure the health system is adopting to improve quality. C is wrong because bureaucratic care is not a recognized healthcare payment model. Bureaucratic structures describe hierarchical organizational systems with strict rules, rather than reimbursement approaches tied to patient outcomes, quality, or cost effectiveness. D is wrong because the biomedical model focuses on diagnosing and treating disease through biological factors, which is a clinical approach rather than a reimbursement structure tying provider payment to patient outcomes and quality measures. Value-based care is a payment philosophy that ties provider reimbursement to the quality and outcomes of care, rather than the sheer volume of services delivered. Value itself is defined as health outcomes achieved per dollar spent. The mechanism links payment to measured performance. Providers are held accountable for quality metrics and total cost, sharing in savings when care improves. Because avoiding complications is now financially rewarding, prevention and care coordination become the sensible path. The contrast with fee-for-service is the key distinction. Fee-for-service rewards volume. More services mean more revenue regardless of patient improvement. Value-based care rewrites that incentive so that better, more efficient care becomes the profitable path. When a question stem describes reimbursement tied to outcomes, quality metrics, or cost effectiveness rather than service counts, value-based care is the model in play. Watch for these signal words to distinguish it from both fee-for-service and patient-centered care. Remember, value-based care is defined specifically by its financial linkage. Patient-centered care overlaps in spirit but is about involving patients in decision, not a payment model. If money follows results, you are looking at value-based care. Question 17. A clinic administrator notices that under their current payment system, providers earn more revenue by ordering additional tests, procedures, and follow-up visits regardless of whether patient outcomes improve at all. Which traditional payment model is creating these volume-based financial incentives in the clinic? Your options are A. Shared savings model, B. Value-based care model, C. Capitation payment model, D. Fee-for-service model. Which one is it? Pause the video if you need more time. The correct answer is D. Fee-for-service model. D is correct because fee-for-service reimburses providers for each service, test, or procedure performed, which creates financial incentives to increase volume regardless of outcomes, matching exactly what the clinic administrator is observing in provider ordering behavior. A is wrong because shared savings models reward providers for reducing costs while maintaining quality, which creates incentives opposite to ordering more tests and procedures. So this model does not explain volume-driven revenue patterns. B is wrong because value-based care rewards quality and outcomes rather than service volume, so it would discourage ordering unnecessary tests and procedures, which is the opposite of the pattern the administrator is currently observing. C is wrong because capitation pays providers a fixed amount per patient regardless of services delivered, which would discourage ordering additional unnecessary tests and procedures, rather than incentivizing the volume-based revenue behavior described here. Fee-for-service is the traditional payment model where providers are paid separately for each service, test, or visit they deliver. Understanding its incentive structure is the key to recognizing it on any exam. The mechanism is direct. Each service carries a price. The provider performs that service, and payment follows the count. More services delivered means more revenue earned, regardless of whether patient health improves. The model rewards volume alone. There is no financial reward for prevention, coordination, or efficiency, because those reduce billable activity. A provider who keeps patients healthy earns less than one who treats illness episode by episode. The exam tests your ability to distinguish fee-for-service from value-based care, capitation, and shared savings. All three alternatives flip the incentive away from volume. Fee-for-service stands alone as the model that rewards doing more, not doing better. Whenever a scenario describes income rising with the quantity of services delivered, which might sal wise more tests, more visits, more procedures, that is fee-for-service. The tell is always that the payment structure itself drives the behavior. Question 18. A hospital system joins a federal program that requires meeting specific quality metrics, such as 30-day readmission rates, in exchange for sharing in cost savings generated by improving care. Which program does this arrangement describe within the value-based care landscape? Your options are A. Affordable Care Act, B. Medicare Shared Savings Program, C. HIPAA Privacy Program, D. False Claims Act. Take a second. Which answer would you pick? The correct answer is B. Medicare Shared Savings Program. B is correct because the Medicare Shared Savings Program incentivizes providers to reduce costs while meeting quality metrics like 30-day readmission rates, which directly matches the federal arrangement the hospital system has just entered into here. A is wrong because the Affordable Care Act is broader legislation that expanded insurance coverage and reformed healthcare delivery, rather than a specific shared savings program tied to readmission metrics and cost reduction incentives between providers and payers. C is wrong because HIPAA governs patient privacy and the security of medical records, rather than provider reimbursement or shared savings arrangements tied to quality metrics such as 30-day readmission rates for hospitalized patients. D is wrong because the False Claims Act prevents fraudulent billing and false submissions to government payers, which is a compliance law rather than a shared savings program linked to quality metrics and cost reduction incentives. The Medicare Shared Savings Program is a federal value-based care initiative that rewards providers for reducing costs while meeting quality standards. It's the concrete mechanism that turns the shift from volume to value into something providers can actually participate in financially. Providers form an accountable care organization, or ACO, and take responsibility for a defined Medicare population. Their spending is compared against a benchmark. If they come in under budget while hitting quality metrics like the 30-day readmission rate, they keep a portion of the savings. Quality gates are built into the design. Savings are only paid out when standards are met, preventing providers from cutting corners on care just to reduce spending. This pairing of a cost benchmark with quality requirements is the program's defining feature. Exam writers test whether you can distinguish the specific program from related concepts. The Affordable Care Act created MSSP but is far broader. HIPAA governs privacy, not payment. The False Claims Act addresses fraudulent billing. MSSP alone is the narrow outcome-based shared savings mechanism. When a scenario describes a federal program where providers share in cost savings only after meeting quality metrics, think readmission rates and benchmarks. That's the Medicare Shared Savings Program. The pairing of quality targets with shared savings is your signal. Question 19. A hospital administrator leading the shift from fee-for-service to value-based care faces pushback from clinicians accustomed to volume-based revenue, along with significant upfront costs for new data systems and workflow changes. Which statement best captures the primary challenges of this organizational transition? Your options are A. No financial investment required. B. Unanimous staff support guaranteed. C. Resistance and initial cost. D. Immediate revenue increases expected. Before I reveal it, which one do you think is right? The correct answer is C. Resistance and initial cost. C is correct because transitioning to value-based care typically faces staff resistance from clinicians used to fee-for-service payment, plus high implementation costs for data systems and workflow redesign, which matches the administrator's primary challenges exactly as described. A is wrong because claiming no financial investment is required contradicts the reality that value-based care transitions demand substantial upfront spending on data analytics, reporting systems, training, and workflow redesign to track outcomes effectively. B is wrong because unanimous staff support is rarely guaranteed during major payment model transitions, since clinicians accustomed to volume-based revenue often resist changes that alter their workflows, compensation structures, and clinical decision-making autonomy. D is wrong because expecting immediate revenue increases during a value-based care transition is unrealistic, since initial investment costs and workflow disruption typically reduce short-term revenue before long-term outcome-based gains materialize for the organization. Shifting an organization from fee-for-service to value-based care is one of healthcare's most complex transformations. Two obstacles reliably appear: resistance from people and the upfront cost of change itself. Understanding both is essential to understanding why progress has been slow even when the goal is widely supported. The shift is uniquely difficult because it asks organizations to rewire both incentives and habits simultaneously. Clinicians build careers under volume-based payment, with workflows, expectations, and compensation all tied to the old model. People rarely welcome changes that threaten established routines and income. The difficulty has two distinct strands. The behavioral strand involves staff resistance when clinicians lose autonomy or face changes to how they work and are paid. The financial strand involves heavy upfront investment in analytics, training, and workflow redesign, all spending that arrives before any outcome-based rewards appear. During the transition period, organizations spend more before they earn differently. New analytics platforms, redesigned processes, and change management programs all demand resources upfront. Leaders who expect instant gains are typically disappointed. The honest picture is resistance plus initial cost before rewards arrive. When exam scenarios describe clinician pushback alongside heavy spending on new systems, that is the genuine challenge being captured, not a sign of failure. Neither problem is avoidable, and both must be managed for the transformation to succeed. Question 20. A primary care clinic redesigns visits to actively involve patients and their families in treatment decisions, respects individual preferences and cultural values, and tailors care plans around each patient's specific goals and circumstances. Which care approach does this describe? Your options are A. Patient-centered care, B. Fee-for-service care, C. Bureaucratic care, D. Biomedical care. What's your answer? Commit to one before I continue. The correct answer is A. Patient-centered care. A is correct because patient-centered care actively involves patients and families in decisions, respects preferences and cultural values, and personalizes treatment around individual goals, which precisely describes the redesigned visit approach at the primary care clinic described. B is wrong because fee-for-service is a payment model based on service volume rather than a philosophy of care delivery, so it does not describe the collaborative, preference-respecting approach the clinic has implemented in its visits. C is wrong because bureaucratic care implies rigid rules and hierarchical structures rather than personalized, collaborative decision-making with patients and families, so it fails to capture the individualized, preference-respecting approach this clinic now demonstrates. D is wrong because the biomedical model focuses narrowly on biological disease causes and clinical treatment, without emphasizing patient preferences, cultural values, or shared decision-making that define the individualized approach the clinic has adopted. Patient-centered care organizes treatment around the individual patient's values, preferences, and goals, treating the patient as a partner, not a passive recipient. The organizing idea is respect for the whole human being. The model works through 4 essentials: shared decision-making, respect for cultural and personal values, family involvement, and care plans built around each patient's own goals. Communication and dignity are treated as clinical necessities, not extras. Patient-centered care arose as a direct corrective to the biomedical model, which focused narrowly on disease while overlooking what the patient wanted. As medicine grew more technical, outcomes suffered when care plans ignored a patient's circumstances or wishes. The key exam distinction is that patient-centered care is a care philosophy, about how care is delivered and who shapes it, not a payment model. Fee-for-service and value-based care are reimbursement structures. When a scenario describes personalized, collaborative, preference-driven care, patient-centered care is the answer. The tell is always involvement and personalization. Engaged patients who help shape their own care adhere better, recover better, and report far higher satisfaction. The care adapts to the patient, never the other way around. Question 21. A newly appointed hospital director spends her first weeks analyzing current operations, anticipating future regulatory changes, setting 5-year strategic objectives, and determining the best course of action to achieve organizational goals. Which core management function is she primarily performing? Your options are A. Controlling function, B. Organizing function, C. Directing function, D. Planning function. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Planning function. D is correct because planning involves setting objectives, analyzing current situations, anticipating future developments, and determining the best course of action to achieve goals, which precisely matches the new hospital director's early strategic activities described here. A is wrong because controlling involves monitoring performance against standards and taking corrective action, which occurs after plans are in place, rather than the forward-looking strategic analysis and objective setting the new director is currently performing. B is wrong because organizing involves arranging resources, defining roles, and establishing internal structures to execute existing plans, rather than the initial analysis, objective setting, and strategic anticipation the director is conducting during these early weeks. C is wrong because directing involves guiding and motivating employees to achieve objectives through communication and inspiration, rather than the analytical, future-oriented strategic activity of setting goals and determining approaches the director is performing. Planning is the management function that looks forward. It happens before any resources are arranged or work begins. It sets the destination that every other management activity exists to reach. Planning involves 4 core activities: setting objectives, analyzing the current situation, anticipating future conditions, and deciding in advance the best course of action. Notice that all four happen before anyone organizes, staffs, directs, or controls anything. Henri Fayol, writing in the early 20th century, recognized that management means shaping events, not just reacting to them. Planning sits first in a sequence because organizing, staffing, directing, and controlling all depend on objectives that planning produces. The key distinction exam writers test is this: planning is about deciding what to do, not yet doing it. Organizing arranges resources, directing motivates people to execute, and controlling monitors results. All three come after the plan exists. When a scenario describes a leader setting multi-year objectives, forecasting changes, or determining a course of action, with no reorganizing or monitoring yet, that is planning. Signal words include set objectives, anticipate, forecast, and strategic plan. Question 22. A nursing manager regularly reviews budget reports, compares unit productivity against established benchmarks, tracks patient satisfaction scores, and takes corrective action whenever key metrics fall below expected performance standards. Which core function of management is the nursing manager actively performing here? Your options are A. Planning function, B. Controlling function, C. Staffing function, D. Directing function. Which would you go with? Lock it in before the reveal. The correct answer is B. Controlling function. B is correct because controlling involves monitoring performance, comparing it with standards, and taking corrective action when needed, which matches the manager's regular review of budgets, productivity benchmarks, satisfaction scores, and timely corrective interventions exactly. A is wrong because planning involves setting objectives and determining approaches before action begins, rather than the ongoing monitoring, comparison, and corrective action activities the nursing manager is performing across budget and performance metrics currently. C is wrong because staffing focuses on recruitment, training, and retention of employees to fill roles, rather than the performance monitoring and corrective action work the manager is conducting with established benchmarks and satisfaction scores. D is wrong because directing focuses on guiding, motivating, and inspiring employees toward objectives, rather than the measurement and corrective intervention activities described, where the manager evaluates metrics and adjusts based on deviations from standards. Controlling is the management function that checks whether plans are actually working. It measures real performance against established standards and takes corrective action when results fall short. This is what separates organizations that fly blind from those that stay on course. The mechanism works as a continuous loop. Leaders establish benchmarks, gather data on actual performance, compare the two, and act on any gap they find. Corrective action might mean retraining staff, reallocating resources, or revising a process entirely. In healthcare, this cycle shows up as budget variance reviews, productivity benchmarks, patient satisfaction tracking, and quality dashboards that trigger intervention when a metric slips below its threshold. The functions most confused with controlling are planning, staffing, and directing. Planning sets the standards in the first place. Staffing fills roles. Directing motivates people. Controlling alone performs the backward-checking comparison of results against standards and responds with correction. When an exam stem describes a manager monitoring metrics, comparing output against benchmarks, and stepping in to fix shortfalls, that is controlling. The unmistakable tell is measurement against a standard followed by corrective action. Question 23. An emergency department administrator arranges workstations, defines specific roles for triage nurses and physicians, allocates equipment and supplies strategically, and creates clear systems for patient flow. Which core management function best captures what the administrator is accomplishing through these activities? Your options are A. Controlling function, B. Planning function, C. Organizing function. D. Directing function. Don't overthink it. Which one feels right? The correct answer is C. Organizing function. C is correct because organizing involves arranging resources, defining roles and responsibilities, allocating equipment, and creating internal systems, which precisely matches the administrator's work on workstations, role definitions, resource allocation, and patient flow structures throughout. A is wrong because controlling involves monitoring performance against standards and taking corrective action, which differs from the structural setup activities of arranging workstations, defining roles, and allocating resources the administrator is performing here. B is wrong because planning focuses on setting strategic objectives and analyzing situations to determine direction, rather than the structural, role defining, and resource arranging activities the administrator is accomplishing within the emergency department operations described. D is wrong because directing focuses on guiding and motivating employees to achieve goals through inspiration and communication, rather than the structural arrangement of roles, workstations, equipment, and patient flow systems the administrator is completing. Organizing is the management function that transforms a plan into an operating structure. It answers not what to do, but who does what, with what resources and in what arrangement. Specifically, organizing means defining roles, allocating resources, establishing who reports to whom, and designing the workflow that links all the pieces into a coherent, functioning unit. Picture an emergency department administrator who positions workstations, assigns distinct roles to triage nurses and physicians, places equipment where it will be needed, and maps a clear path for patient flow. That deliberate construction of structure is organizing in action. Organizing is easy to confuse with its neighbors. Planning sets the objectives before any structure exists. Directing motivates people once roles are in place. Controlling monitors performance after work begins. Organizing is the setup task in between, arranging roles, resources, and relationships so that work can actually run. When a scenario describes arranging resources, defining roles, allocating equipment, or building workflow systems, that is the organizing function. Structure is its product, and structuring is its tell. Question 24. A rural hospital human resources director focuses on recruiting qualified nurses, coordinating comprehensive onboarding and training programs, developing retention strategies, and ensuring the facility has the right talent mix to meet ongoing patient care demands. Which management function is she fulfilling? Your options are A. Staffing function, B. Organizing function, C. Directing function, D. Controlling function. Got a guess? Lock it in. The correct answer is A. Staffing function. A is correct because staffing focuses on identifying suitable personnel for roles and ensuring the organization has necessary talent through recruitment, training, and retention efforts, which directly matches the Human Resources Director's current responsibilities at the rural hospital. B is wrong because organizing involves arranging resources and defining roles within existing structures, rather than the workforce-specific recruitment, onboarding, training, and retention activities that define the staffing function the director is clearly performing. C is wrong because directing focuses on guiding and motivating current employees toward goals through communication and inspiration, rather than the recruitment, training, and retention activities described for the rural hospital's Human Resources Director's role. D is wrong because controlling involves monitoring performance and taking corrective action against established standards, which differs from the workforce acquisition, development, and retention activities the director is managing to meet patient care demands. Staffing is the management function focused on acquiring, developing, and keeping the right people in an organization's roles. It's not about designing those roles or motivating the people already in them. It's about filling the seats with capable, committed individuals. Staffing spans the entire employment life cycle. It begins with recruiting and selecting candidates, moves into onboarding and training new hires, and continues with development and retention strategies designed to hold on to valued employees. It helps to see where staffing sits among the other management functions. Organizing defines the roles. Staffing fills them with people and grows them. Directing then motivates those people, and controlling measures their output. Each function is distinct, and the key to staffing is that people, not tasks or results, are its central concern. When reading an exam stem, watch for these signal words: recruit, hire, onboard, train, retention, and right talent mix. Any scenario built around acquiring and developing the workforce is pointing to the staffing function. In healthcare especially, where patient outcomes depend on having enough qualified clinicians, staffing is never a background task. When a scenario is about getting the right people into seats and keeping them there, that is staffing every time. Question 25. A clinic manager regularly communicates organizational vision during team meetings, motivates staff through recognition and encouragement, inspires commitment to shared goals, and facilitates teamwork between clinical and administrative departments. Which core function of management is she primarily carrying out? Your options are A. Planning function, B. Directing function, C. Staffing function, D. Organizing function. Which one is it? Pause the video if you need more time. The correct answer is B. Directing function. B is correct because directing involves guiding and motivating employees to achieve objectives by communicating goals, inspiring commitment, and facilitating teamwork, which directly matches the clinic manager's activities of sharing vision and motivating staff across departments. A is wrong because planning involves setting objectives and analyzing situations before execution, rather than the active motivation, vision sharing, and teamwork facilitation activities the clinic manager is performing day to day with clinical and administrative staff. C is wrong because staffing focuses on recruitment, training, and retention of employees to fill organizational roles, rather than the inspiration, motivation, vision communication, and teamwork facilitation activities the clinic manager is carrying out here. D is wrong because organizing involves arranging resources, defining roles, and establishing internal structures, rather than the motivational communication and teamwork building activities the clinic manager is performing to inspire commitment to shared organizational goals. Directing is the management function that turns plans and structures into action, while other functions arrange the conditions for work. Directing energizes the human beings who actually perform it at suites, guiding, motivating, and inspiring employees toward shared goals. The directing manager conveys the vision, explains expectations, recognizes good work, and fosters teamwork. Leadership style, emotional intelligence, and motivational insight all live inside this function, because directing is fundamentally about influencing human behavior toward shared goals. Picture a clinic manager who shares the organizational vision at team meetings, motivates staff through recognition, and smooths cooperation between clinical and administrative departments. She is not auditing results or arranging job roles. She is moving people to act, which is the essence of directing. Directing is easy to confuse with planning, staffing, and organizing. Planning sets the goals. Staffing brings people in. Organizing arranges roles and resources. Directing is the one function aimed squarely at motivating and guiding those people once everything else is in place. When a scenario describes a leader communicating vision, inspiring commitment, or facilitating teamwork, that is directing. The signal words are motivate, inspire, encourage, and lead, all pointing to the function that turns a capable workforce into an engaged one. Question 26. A hospital administrator notices that positive workplace events like peer recognition and supportive teamwork consistently boost nursing staff engagement, while negative events like understaffing trigger burnout and disengagement. Which theory explains how these workplace events trigger emotional reactions that affect performance? Your options are A. Affective events theory, B. Vroom's expectancy theory, C. McGregor's theory X, D. Tuckman's group theory. Take a second. Which answer would you pick? The correct answer is A. Affective events theory. A is correct because affective events theory, developed by Weiss and Cropanzano, explains how workplace events trigger emotional reactions that affect job performance and attitudes, which matches the administrator's observations about engagement and burnout patterns perfectly. B is wrong because Vroom's expectancy theory explains motivation through personality, skills, and desire for rewards, rather than describing how specific workplace events triggered emotional reactions that influence job performance and employee engagement levels. C is wrong because McGregor's theory X assumes employees dislike work and need coercion, which is a managerial assumption framework rather than a theory explaining emotional reactions to workplace events and their performance effects on staff. D is wrong because Tuckman's group theory describes 5 stages of team development from forming through adjourning, which focuses on team dynamics rather than explaining how workplace events trigger emotional responses affecting individual performance. Affective events theory explains how specific workplace events trigger emotional reactions and how those emotions then shape employee attitudes and performance. It treats job satisfaction not as a fixed trait, but as something built moment to moment from the emotional residue of daily work life. The core mechanism is a chain. A work event provokes an immediate emotional reaction, which directly influences behavior in the moment and feeds into longer-term attitudes like satisfaction and commitment. Features of the work environment shape which events occur, while individual differences shape how strongly people react. It's easy to confuse this theory with others. Expectancy theory explains motivation through calculations about effort, performance, and reward, not emotional reactions. Theory X is an assumption about worker attitudes, not a model of emotion. Tuckman describes team development stages. Affective events theory uniquely traces performance back to the emotions that workplace events provoke. When a scenario describes events sparking feelings that shape behavior or engagement, affective events theory is the concept being identified. The tell is that explicit causal path running from workplace events through emotional reactions all the way to performance outcomes. Question 25. A department director excels at recognizing her own emotional reactions, managing frustration constructively, reading the emotional states of her team members, and building supportive relationships during stressful workplace situations. Which leadership competency is she demonstrating through these interpersonal capabilities every day? Your options are A. Situational adaptability, B. Cognitive dissonance, C. Emotional intelligence, D. Transactional compliance. Before I reveal it, which one do you think is right? The correct answer is C. Emotional intelligence. C is correct because emotional intelligence comprises self-awareness, self-management, social awareness, and relationship management, which precisely matches the director's abilities to recognize her emotions, manage frustration, read others, and build supportive team relationships. A is wrong because situational adaptability refers to adjusting behavior based on changing circumstances, which is a broader concept that does not specifically capture the four-component emotional framework of self-awareness, self-management, social awareness, and relationship management. B is wrong because cognitive dissonance describes psychological stress from misalignment between emotions, attitudes, and behaviors, which is a specific internal conflict phenomenon rather than the broader interpersonal competency framework the director is actively demonstrating. D is wrong because transactional compliance refers to following rewards and punishment systems within transactional leadership approaches, which has nothing to do with recognizing emotions, managing feelings, or building supportive relationships the director demonstrates consistently. Emotional intelligence is the capacity to recognize and manage your own emotions while skillfully perceiving and responding to the emotions of others. In leadership, it's what separates technically capable managers from truly effective ones. The framework rests on four components that build on each other. Self-awareness means recognizing your emotions as they arise. Self-management is regulating them constructively. Social awareness is reading others' emotional states through empathy. Relationship management uses all of that to build trust and resolve conflict. Notice how the four components layer. You cannot manage others' emotions well without first managing your own. The self-directed skills form the foundation that makes the other directed skills possible. Emotional intelligence is often confused with related but distinct ideas. Adaptability is adjusting to change broadly. Cognitive dissonance is the discomfort of holding conflicting beliefs, an internal conflict, not a competency. Transactional compliance is a rewards and penalties system. None of these capture the four-part mastery of emotion that defines ER. When an exam STEM describes a leader who manages her own frustration, reads her team's unspoken struggles, and builds lasting trust, that combination of self-directed and other-directed emotional skill is the signature of emotional intelligence. Question 28. A nurse manager notices that staff need both basic necessities like fair pay, reasonable workloads, and safe working conditions, along with higher level opportunities like professional growth and meaningful recognition on the job. Which motivation theory captures this layered view of employee needs? Your options are Pascal theory, B. McGregor's theory X, C. Affective events theory, D. Maslow's hierarchy of needs. What's your answer? Commit to one before I continue. The correct answer is D. Maslow's hierarchy of needs. D is correct because Maslow's hierarchy of needs describes how employees require fulfillment of basic physiological and safety needs alongside higher level needs like esteem and self-actualization, which matches the manager's observation about layered staff requirements precisely. A is wrong because path goal theory focuses on how leaders clear obstacles and provide support to motivate subordinates, rather than describing a layered hierarchy of basic and higher level human needs that Maslow's framework specifically addresses. B is wrong because McGregor's theory X assumes employees inherently dislike work and require coercion to perform, which is a pessimistic managerial assumption rather than a framework describing a hierarchy of basic and higher level needs. C is wrong because affective events theory explains how specific workplace events trigger emotional reactions affecting performance, which is fundamentally different from describing a tiered structure of basic and self-actualization needs that drive employee motivation. Maslow's hierarchy of needs is a theory of human motivation built on a simple but powerful insight. People must satisfy lower, more basic needs before higher ones become motivating. Understanding this layered structure is what sets Maslow apart from every other motivation theory. The hierarchy has 5 levels. Physiological needs sit at the base, fair pay and reasonable conditions. Safety needs follow, then belonging, then esteem, and finally self-actualization at the top, the drive to grow and reach one's full potential. In a workplace context, a manager who ignores the base layer, fair pay and safe conditions, we too, cannot motivate staff with recognition or growth opportunities alone. Each layer must be reasonably met before the next one becomes a strong motivator. Maslow is often confused with three other theories. Path goal theory is about leaders removing obstacles. McGregor's theory X is a pessimistic assumption about workers. Affective events theory links workplace events to emotions. Only Maslow ranks motivators on an ascending ladder from survival to self-fulfillment. When a question describes motivation through tiers of needs, from physiological and safety at the base up through esteem and self-actualization, Maslow's hierarchy is the answer. Look for the explicit layering and the idea that lower needs take precedence. Question 29. A clinic director believes her employees are naturally motivated, genuinely enjoy meaningful work, and thrive when given opportunities for autonomy, growth, and creative problem solving. She designs management practices around trust and empowerment rather than control. Which theory reflects her assumptions? Your options are A. McGregor's theory Y, B. McGregor's theory X, C. Fiedler contingency model, D. bureaucratic theory. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. McGregor's theory Y. A is correct because McGregor's theory Y assumes employees are intrinsically motivated, enjoy work, and seek growth opportunities, which matches the clinic director's belief that staff thrive under trust, autonomy, and empowerment rather than control mechanisms. B is wrong because McGregor's theory X assumes employees dislike work and require coercion, which is the direct opposite of the clinic director's trust-based, empowerment-oriented assumptions about her staff's intrinsic motivation and natural drive. C is wrong because Fiedler's contingency model argues leadership effectiveness depends on situation, and that leader style is innate, rather than describing assumptions about whether employees are intrinsically motivated versus requiring external coercion and close supervision. D is wrong because bureaucratic theory emphasizes hierarchical structure, strict rules, and top-down control, which conflicts with the clinic director's philosophy of trust, autonomy, and empowerment that assumes employees are self-motivated and capable professionals. Theory Y is Douglas McGregor's optimistic framework for understanding what motivates people at work. Introduced in 1960, it argues that employees are naturally self-motivated, find satisfaction in meaningful work, and will seek responsibility when given the opportunity. McGregor contrasted two opposing mindsets. Theory X assumes workers dislike work and require control. Theory Y assumes the opposite, that people are driven from within and grow when trusted with real autonomy. The key mechanism is the link between belief and practice. A manager who trusts her staff delegates authority, invites participation, and creates room for growth. Those conditions draw out exactly the engaged, responsible behavior she expected, making the assumption self-fulfilling. When reading a scenario, certain signal words point directly to theory Y. Employees who are intrinsically motivated, who enjoy their work, who seek responsibility, and managers who build around autonomy, trust, and empowerment rather than monitoring and rules. The most common error is confusing theory Y with theory X, its pessimistic twin. If a scenario describes a leader who believes people are naturally driven and builds her management around that belief, that is theory Y every time. Question 30. A hospital administrator observes that employee motivation depends heavily on whether staff believe their effort will lead to good performance, whether that performance will be rewarded, and whether they actually value the offered rewards. Which theory captures this motivation framework? Your options are A. Maslow's hierarchy, B. Hertzberg's two-factor theory, C. Vroom's expectancy theory, D. Goal-setting theory. Which would you go with? Lock it in before the reveal. The correct answer is C. Vroom's expectancy theory. C is correct because Vroom's expectancy theory explains motivation through expectancy, instrumentality, and valence, meaning effort-performance linkage, performance-reward linkage, and value of rewards, which directly matches the administrator's three-part observation about employee motivation patterns. A is wrong because Maslow's hierarchy describes layered human needs from physiological to self-actualization, rather than explaining motivation through the specific cognitive linkages between effort, performance, rewards, and personal value that Vroom's theory addresses. B is wrong because Hertzberg's two-factor theory distinguishes hygiene factors from motivators, rather than describing the cognitive calculation of effort performance reward expectancies that drive motivation according to the administrator's observations about his staff. D is wrong because goal-setting theory by Locke emphasizes challenging, specific goals with resources and feedback to drive performance, rather than describing the expectancy calculations linking effort, performance, and valued rewards in employee motivation. Expectancy theory frames motivation as a calculation, not a feeling. Before investing effort, people silently ask 3 questions, and if any answer is weak, motivation collapses entirely. Expectancy is the belief that effort will produce strong performance. Instrumentality is the belief that strong performance will actually be rewarded. Valence is how much the person values that reward. Motivation is only strong when all 3 are high. A weak link anywhere drains the whole. The 3 judgments form a chain. Effort must connect to performance. Performance must connect to reward. And the reward must carry personal value. Vroom captured this as a multiplicative relationship. If any factor reaches 0, the product is 0. Exam questions often pair expectancy theory against Maslow's need hierarchy, Hertzberg's two-factor model, and goal-setting theory. The tell for Vroom is explicit conditional reasoning. Effort leads to performance. Performance leads to reward, and the reward is valued. Vroom's insight was that motivation depends on beliefs, not just needs. When a scenario describes motivation hinging on whether effort pays off and whether the payoff is worth wanting, that conditional chain points squarely at expectancy theory. Question 31. A newly assembled quality improvement team meets for the first time, with members uncertain about their roles, cautious in their interactions, and looking to leadership for clear direction and objectives. Which stage of Tuckman's group development model does this describe? Your options are A. Storming stage, B. Performing stage, C. Norming stage, D. Forming stage. Don't overthink it. Which one feels right? The correct answer is D. Forming stage. D is correct because the forming stage features team members uncertain about their roles with cautious interactions, requiring leadership to set clear objectives and direction, which precisely matches the newly assembled quality improvement team's current dynamics. I goes wrong because the storming stage involves conflict emerging as team members push against roles and processes, which differs from the initial uncertainty and cautious early stage interactions the newly assembled quality improvement team is experiencing. B is wrong because the performing stage reflects a mature team achieving goals with less management oversight, which is the opposite of the uncertain, direction-seeking initial stage the newly assembled team is currently experiencing together. C is wrong because the norming stage involves relationships forming as the team focuses on group goals after earlier conflicts, which comes after storming and contrasts with the first meeting uncertainty the new team is experiencing. The forming stage is the very first phase of Tuckman's 1965 model of team development. Understanding it means recognizing what a brand new group looks like and what kind of leadership it actually needs. During forming, members are polite but uncertain, cautious in how they interact, and heavily dependent on the leader for goals and structure. Genuine disagreements stay submerged because trust hasn't been established yet, so productivity naturally runs low. Tuckman observed that nearly every team moves through the same arc: forming, storming, norming, and performing. Naming these stages gave managers a way to recognize where a group stands and respond to what it needs at that moment. Forming is often confused with storming, norming, and performing. The key distinction is that forming is tentative and orienting. No conflict has surfaced yet, no cohesion has formed, and no autonomy has developed. When a scenario describes a team meeting for the first time, unsure of roles and looking to leadership for direction, that's the forming stage. Strong, clear direction from the leader is exactly what this phase calls for. Question 32. A project team working on a new patient care initiative begins experiencing open disagreements about priorities, communication friction between members, and visible conflict over leadership roles. Which stage of Tuckman's group development model best characterizes this challenging team phase? Your options are A. Storming stage, B. Forming stage, C. Performing stage, D. Adjourning stage. Got a guess? Lock it in. The correct answer is A. Storming stage. A is correct because the storming stage features conflict emerging among team members over roles, priorities, and communication, requiring management to foster collaboration and relationship building, which precisely matches the project team's current disagreements and friction. B is wrong because the forming stage features initial uncertainty and cautious interactions as members get oriented, which differs from the open disagreements, communication friction, and visible conflict characterizing the project team's current challenging phase. C is wrong because the performing stage reflects mature teams achieving goals smoothly with minimal oversight, which is the opposite of the open disagreements, communication friction, and role conflict the project team is currently navigating. D is wrong because the adjourning stage involves the team dissolving after completing goals, with management providing praise and closure, which does not match the active conflict and unresolved role tensions the project team is experiencing. The storming stage is the second phase of Tuckman's model, and it marks the moment when early politeness breaks down and real conflict emerges. Far from being a sign of failure, storming is a necessary developmental task, the collision of individual perspectives that genuine teamwork requires. Tuckman identified 4 stages: forming, storming, norming, and performing. Storming sits between the calm beginning and the resolution that follows. It is the turbulent middle where differences are aired and fought through rather than avoided. During storming, members assert themselves, pushing back on assigned roles and competing over priorities and approaches. The leader's task shifts from simple direction toward coaching, keeping disagreements productive so tension resolves rather than hardens into dysfunction. The key exam skill is distinguishing storming from the stages around it. Forming is cautious politeness before conflict erupts. Norming is resolution after conflict settles. Performing is mature productivity. Storming is the conflict phase, active surface disagreement that is still unresolved. When a scenario describes open disputes over roles, friction in communication, and visible clashes over leadership, that is storming, a group that works through this stage builds the honest relationships every later stage depends on. Question 33. After weeks of early conflict, a surgical unit's process improvement team has settled into productive relationships, shared expectations, and clear agreement on goals. Members now collaborate effectively towards their common objectives. Which Tuckman stage best describes this team's current development phase? Your options are A. Forming stage, B. Norming stage, C. Storming stage, D. Adjourning stage. Which one is it? Pause the video if you need more time. The correct answer is B. Norming stage. B is correct because the norming stage features relationships forming after earlier conflicts with focus shifting to shared group goals and collaborative agreement, which precisely matches the surgical unit team's productive relationships and clear objective alignment. A is wrong because the forming stage features initial uncertainty and role ambiguity during the team's first interactions, which is earlier than the mature collaborative phase the surgical unit team has now reached after weeks. C is wrong because the storming stage involves active conflict over roles and priorities, which the surgical unit team has already moved past, now operating in productive collaboration with shared expectations and agreement on common goals. D is wrong because the adjourning stage involves team dissolution after goals are achieved, which has not yet occurred since the surgical unit team is still actively working together, productively toward their shared improvement objectives. The norming stage is Tuckman's third phase of team development, marking the turning point where conflict finally resolves and genuine cooperation takes hold. Trust replaces friction and the team begins to function as a real unit. Tuckman identified that once a group works through its disputes, it enters norming, where members accept their roles, establish shared expectations, and commit to common goals. These unwritten rules are what allow a team to coordinate smoothly. During norming, 4 key shifts occur. Members accept their roles, shared expectations emerge, mutual trust replaces friction, and the leader can step back from mediating every dispute as the team begins to manage itself. Exam writers test whether you can distinguish norming from the stages surrounding it. Forming is the tentative beginning before conflict. Storming is unresolved friction. Performing is the later high-efficiency peak. Norming is the bridge. Conflict is behind the team, but peak performance is still ahead. When a scenario describes a team that has moved past early conflict into productive relationships and agreement on goals, that is norming. Look for signal words like settled, cohesion, shared expectations, and cooperation after conflict. Question 34. An experienced interdisciplinary care team now operates with minimal management oversight, consistently achieves its goals, self-directs complex cases, and demonstrates high trust and efficiency among members. Which stage of Tuckman's group development model best captures this team's maturity level? Your options are A. Forming stage, B. Storming stage, C. Norming stage, D. Performing stage. Take a second. Which answer would you pick? The correct answer is D. Performing stage. D is correct because the performing stage features mature teams achieving goals with minimal management oversight, operating with trust, self-direction, and high efficiency, which precisely matches the interdisciplinary care team's current advanced level of operational maturity. A is wrong because the forming stage features initial uncertainty and role ambiguity requiring heavy leadership guidance, which is the opposite of the self-directed, minimal oversight maturity the interdisciplinary care team now consistently demonstrates in practice. B is wrong because the storming stage involves active conflict and friction over roles and priorities, which is incompatible with the high trust, efficiency, and smooth goal achievement the interdisciplinary care team now consistently demonstrates. C is wrong because the norming stage involves relationships settling and goals aligning after earlier conflicts, which represents an earlier phase than the highly efficient, self-directed performing level maturity the interdisciplinary team has now achieved. The performing stage is the fourth and most mature phase of Tuckman's model, representing the payoff of everything the team worked through before. This is when a group reaches peak effectiveness and largely runs itself. A performing team shows 4 key hallmarks: deep mutual trust, clear and flexible roles with open communication, self-directed problem solving, and minimal need for leader oversight. The leader shifts toward delegation and clearing obstacles rather than guiding every step. Performing cannot be rushed. A team must move through forming, survive the conflicts of storming, and establish shared norms before it can reach this level of autonomous productivity. Skipping those stages means the deep trust performing requires was never built. The stage most often confused with performing is norming, but norming is productive yet not fully autonomous. Storming is the opposite of smooth performance. Performing stands apart as the mature peak of self-directed, high-trust, sustained high output. When a question describes a team operating with minimal oversight, consistently meeting goals, and showing evident trust and efficiency, that is the performing stage, mature self-direction and sustained high output are the tell. Question 35. A hospital's temporary pandemic response task force has successfully completed its mission, and leadership prepares to formally disband the team while acknowledging each member's contributions with praise and recognition. Which Tuckman stage does this closing activity represent within the team life cycle? Your options are A. Norming stage, B. Performing stage, C. Adjourning stage, D. Storming stage. Before I reveal it, which one do you think is right? The correct answer is C. Adjourning stage. C is correct because the adjourning stage involves the team dissolving after achieving its goals, with management providing praise and recognition during closure, which precisely matches the task force disbanding and leadership's acknowledgement of member contributions. A is wrong because the norming stage features relationships forming and group goals aligning mid-life cycle, which occurs before task completion rather than at the formal end when the task force is now being disbanded. B is wrong because the performing stage reflects mature teams actively working together to achieve goals, which differs from the formal closure phase where the task force has completed its mission and is being disbanded entirely. D is wrong because the storming stage involves active conflict over roles and priorities during team development, which is unrelated to the closure, recognition, and disbanding activities happening at the end of the task force life cycle. The adjourning stage is the fifth and final phase of Tuckman's model, added in 1987, more than a decade after the original 4. Unlike every other stage, it is not about building or doing the work. It is about ending deliberately and well. Adjourning has 3 defining elements: completing the remaining work, having leadership formally recognize contributions, and helping members process the emotional weight of separation. A successful team disbanding severs real bonds, so feelings of loss and pride are both common. Tuckman's original model stopped at performing. Real teams, now especially project teams and task forces, eventually finish and dissolve. Naming adjourning acknowledged that closure is itself a developmental task with its own leadership demands. On an exam, 4 signal clusters point to adjourning: disband or dissolve, completion of the mission, recognition and praise from leadership, and closure or wind down language. When a scenario shows a finished team being formally ended with acknowledgement, adjourning is the answer. Adjourning is unique because it marks an end, not a phase of work. When leadership deliberately closes a team with recognition rather than letting it simply evaporate. That is adjourning done right. Question 36. A hospital IT team is reviewing safeguards for electronic medical records, ensuring patient data remains confidential and secure, with strict access controls and breach notification procedures in place across all systems. Which federal law most directly governs these protective requirements? Your options are A. HIPAA, B. Affordable Care Act, C. False Claims Act, D. Social Security Act. What's your answer? Commit to one before I continue. The correct answer is A. HIPAA. A is correct because HIPAA establishes patient privacy protections and security requirements for medical records, including access controls and breach notification procedures, which directly governs the safeguards the hospital IT team is reviewing for electronic records. B is wrong because the Affordable Care Act expanded insurance coverage and emphasized preventive care and value-based payment reforms, rather than specifically governing patient record privacy, security safeguards, and breach notification requirements for electronic medical records. C is wrong because the False Claims Act prevents fraudulent billing and false submissions to government payers, which addresses financial integrity rather than the privacy protections and security safeguards for electronic patient records the team reviews. D is wrong because the Social Security Act established Medicare and Medicaid programs in 1965 to provide healthcare coverage for elderly and low-income Americans, rather than setting privacy standards and security safeguards for electronic patient records. HIPAA is the federal law that sets national standards for protecting the privacy and security of patients' health information. It governs how medical records can be used, shared, and safeguarded, and it gives patients rights over their own data. HIPAA operates through 3 enforceable rules. The privacy rule controls how protected health information is used and shared. The security rule mandates safeguards like access controls and encryption. The breach notification rule requires organizations to alert affected individuals when data is compromised. The security rules safeguards are organized into 3 categories: administrative controls like staff training and policies, physical controls over facilities and devices, and technical controls such as encryption and user access restrictions. Together they form a layered shield around electronic health records. Exam questions often test whether you can distinguish HIPAA from related laws. The Affordable Care Act reformed coverage and payment. The False Claims Act targets fraudulent billing. The Social Security Act created Medicare and Medicaid. Only HIPAA governs the privacy and security of the health record itself. When a scenario involves protecting confidential patient records, access controls, or breach notification, HIPAA is the governing law. Signal words like protected health information, confidentiality, and security safeguards point directly to it. No other major healthcare law covers these protections. Question 37. A state health department reports significant expansion of insurance coverage, new emphasis on preventive care, and value-based payment reforms following a major 2010 federal healthcare law. Which landmark legislation produced these broad changes across the American healthcare landscape? Your options are HIPAA, B. False Claims Act, C. Social Security Act, D. Affordable Care Act. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Affordable Care Act. D is correct because the Affordable Care Act, passed in 2010, expanded insurance coverage, emphasized preventive care, and promoted value-based payment reforms, which precisely matches the broad federal healthcare changes the state health department reports. A is wrong because HIPAA, passed in 1996, governs patient privacy and security of medical records, rather than expanding insurance coverage or promoting preventive care and value-based payment reforms across the American healthcare system nationally. B is wrong because the False Claims Act prevents fraudulent billing submissions to government programs, which addresses financial integrity in healthcare rather than expanding insurance access, promoting preventive care, or reforming payment models toward value. C is wrong because the Social Security Act established Medicare and Medicaid in 1965, which is an earlier landmark healthcare law rather than the 2010 legislation expanding insurance coverage and emphasizing preventive care and value-based payment. The Affordable Care Act is the sweeping 2010 federal law that transformed American healthcare across three major dimensions: who has coverage, what that coverage must include, and how providers get paid. The law works on three fronts simultaneously. It expanded Medicaid for low-income adults and created subsidized insurance marketplaces. It barred insurers from denying coverage for pre-existing conditions and required free preventive services. And it launched value-based payment experiments rewarding quality and efficiency over volume. Coverage expansion happened through two channels. Medicaid eligibility was broadened for low-income adults, while new insurance marketplaces offered subsidized private plans to everyone else, and no one could be turned away for a pre-existing condition. Exam writers test whether you can distinguish the ACA from narrower laws. HIPAA governs privacy, not coverage. The False Claims Act targets fraud. The Social Security Act created Medicare in 1965. Only the ACA is the broad 2010 reform, combining coverage expansion, prevention, and value-based payment. When a scenario describes sweeping reform from 2010, ek voorsien expanded coverage, preventive services, and value-based payment altogether. That combination points to one law, the Affordable Care Act. Question 38. A health policy student researches the 1965 legislation that first created federal healthcare programs for elderly citizens and low-income individuals in the United States, dramatically increasing healthcare access across the country. Which historic law established these two foundational healthcare programs together? Your options are A. Affordable Care Act, B. Health Insurance Portability Act, C. Social Security Act, D. Children's Health Insurance Program. Which would you go with? Lock it in before the reveal. The correct answer is C. Social Security Act. C is correct because the Social Security Act established Medicare and Medicaid in 1965, creating federal healthcare programs for elderly citizens and low-income individuals, which precisely matches the historic legislation the health policy student is currently researching. A is wrong because the Affordable Care Act passed in 2010, not 1965, and while it expanded insurance coverage, it did not originally establish Medicare or Medicaid as the foundational federal programs for elderly and low-income populations. B is wrong because the Health Insurance Portability and Accountability Act passed in 1996 focuses on privacy and record security, and did not create Medicare or Medicaid as the foundational programs for elderly and low-income Americans. D is wrong because the Children's Health Insurance Program was created in 1997 specifically for uninsured children in low-income families, rather than the 1965 legislation that established Medicare and Medicaid for elderly and low-income populations. The Social Security Act, through its 1965 amendments, created two landmark public programs that permanently changed how Americans access health care. Understanding what each program covers, and why 1965 matters, is the key to this concept. Medicare covers people aged 65 and older along with certain disabled individuals, financed through payroll taxes and premiums with uniform benefits nationwide. Medicaid is a joint federal and state program based on financial need, with eligibility that varies by state. Together, they made the government a major payer in American healthcare. While both programs share a 1965 origin, their structures differ. Medicare is purely federal, while Medicaid is administered jointly with the states, meaning the population served and the financing mechanism are distinct by design. Exam questions often test whether you can separate the Social Security Act from later laws. The Affordable Care Act expanded coverage in 2010 but did not create Medicare or Medicaid. HIPAA governs privacy. CHIP covers uninsured children. Only the Social Security Act is the 1965 origin of both Medicare and Medicaid together. Whenever a scenario describes the 1965 law that first established federal health care programs for the elderly and the poor, that is the Social Security Act, the founding of Medicare and Medicaid together in that year is the unmistakable signal. Question 39. A hospital compliance officer investigates a suspected case where a provider submitted inflated billing claims to Medicare for services that were never actually delivered to patients. Which federal law most directly addresses this type of fraudulent billing misconduct and related penalties? Your options are A. HIPAA, B. False Claims Act, C. Affordable Care Act, D. Social Security Act. Don't overthink it. Which one feels right? The correct answer is B. False Claims Act. B is correct because the False Claims Act prevents fraudulent billing and false submissions to government payers like Medicare, which directly addresses the inflated claims for undelivered services the compliance officer is currently investigating at the hospital. A is wrong because HIPAA governs patient privacy and security of medical records rather than addressing fraudulent billing practices submitted to government programs, making it the wrong legal framework for the misconduct the compliance officer is investigating. C is wrong because the Affordable Care Act expanded insurance coverage and promoted value-based payment reforms, rather than specifically governing fraudulent billing submissions to Medicare, which falls under separate compliance legislation with dedicated enforcement mechanisms available. D is wrong because the Social Security Act established Medicare and Medicaid as federal healthcare programs, rather than establishing the specific legal mechanisms for prosecuting fraudulent billing practices submitted to those programs by healthcare providers. The False Claims Act is the federal law that punishes fraudulent billing submitted to government programs. Originally passed in 1863 to stop contractors from cheating the Union Army, it earned the nickname the Lincoln Law and was significantly strengthened in 1986 to combat modern healthcare fraud. In healthcare, the law targets specific fraudulent billing practices. These include charging Medicare for services never delivered, upcoding to more expensive procedures than were actually performed, and submitting inflated or fabricated claims to any government payer. A powerful feature of the law is its qui tam provision, which empowers whistleblowers, private individuals who can sue on the government's behalf and share in any financial recovery. This turns insiders into enforcers, giving employees who spot fraud both a channel and a financial incentive to report it. Exam questions often test whether you can distinguish this law from related statutes. HIPAA governs patient confidentiality. The Affordable Care Act expanded coverage, and the Social Security Act created Medicare and Medicaid. Only the False Claims Act targets the integrity of claims for payment. Whenever a scenario describes inflated, fabricated, or fraudulent claims submitted to Medicare or another government payer, the False Claims Act is the governing law. Signal words include fraud, false claims, upcoding, services never delivered, and whistleblower. Question 40. A health system leader explains that a federal initiative has shifted Medicare reimbursement from paying based on the volume of services delivered to paying based on the value and quality of care provided. Which program represents the significant payment reform effort? Your options are A. Affordable Care Act, B. False Claims Act, C. Medicaid Expansion Initiative, D. Quality Payment Program. Got a guess? Lock it in. The correct answer is D. Quality Payment Program. D is correct because the Quality Payment Program shifted Medicare reimbursement from volume-based to value-based payment models, rewarding quality and outcomes over service quantity, which precisely matches the federal initiative the health system leader is describing. A is wrong because the Affordable Care Act is broader legislation that expanded insurance coverage and laid groundwork for various payment reforms, rather than being the specific program that transitioned Medicare reimbursement from volume-based to value-based payment. B is wrong because the False Claims Act addresses fraudulent billing submissions to government payers, which is a compliance law rather than a payment reform initiative shifting Medicare reimbursement from volume-based to quality-based and value-based models. C is wrong because Medicaid expansion increased eligibility for state-level low-income coverage under the ACA, rather than representing the specific federal program that transitioned Medicare reimbursement from volume-based service payments to value-based quality-focused payments. The Quality Payment Program is the federal initiative that restructured how Medicare pays clinicians, moving away from rewarding sheer volume of services and toward rewarding the value and quality of care delivered. Created by federal legislation in 2015 and launched in 2017, the Quality Payment Program replaced an older, widely criticized physician payment formula. Instead of paying per service, Medicare now pays based on measured quality, cost, and efficiency outcomes. The program offers clinicians two tracks. One adjusts payments up or down based on performance across quality, cost, improvement activities, and certified technology use. The other rewards clinicians who take on meaningful financial risk through advanced alternative payment models. The key distinction exam writers test is recognizing the Quality Payment Program as the specific Medicare initiative that made this volume to value shift. Not broad legislation like the Affordable Care Act, not fraud law like the False Claims Act, and not Medicaid expansion. Whenever a scenario describes a federal initiative tying Medicare reimbursement to quality over quantity, the signal words are volume to value, quality and cost performance, and alternative payment models. That points directly to the Quality Payment Program. Question 41. A public health researcher documents that certain racial and socioeconomic groups in a region experience significantly higher rates of diabetes complications, infant mortality, and chronic disease than other populations in the same community. Which concept best describes these measurable differences? Your options are A. Health equity, B. Cultural competence, C. Health disparity, D. Linguistic competence. Which one is it? Pause the video if you need more time. The correct answer is C. Health disparity. C is correct because health disparity refers to measurable differences in health outcomes between populations, often linked to race, ethnicity, and socioeconomic factors, which precisely describes the patterns the public health researcher is documenting across community groups. A is wrong because health equity refers to ensuring fair opportunities for everyone to achieve optimal health, which is the goal or solution rather than the descriptive term for the measurable outcome differences the researcher is documenting. B is wrong because cultural competence is the ability of providers to deliver care that respects cultural differences, which is a provider capability rather than a term describing measurable outcome gaps between population groups in a community. D is wrong because linguistic competence refers to effective communication across language differences between providers and diverse patients, which is a specific communication capability rather than a term describing measurable outcome differences between racial or socio-economic groups. A health disparity is a measurable, documented difference in health outcomes between population groups. It arises when certain communities carry a disproportionate burden of disease, and that gap tracks with social factors like race, ethnicity, or income rather than biology alone. The key word is measurable. A disparity is not a vague sense of unfairness. It is a documented, quantifiable gap. Researchers identify it by comparing outcomes like infant mortality or diabetes complications across populations and finding a significant pattern difference along social lines. Disparities are identified through comparison. When a researcher measures outcomes across groups in the same community and finds one group consistently faring worse, that documented gap is the disparity itself, the evidence that the social environment is producing unequal health. Students often confuse health disparity with health equity, cultural competence, and linguistic competence. Health disparity is the problem, the measured gap. Health equity is the goal of closing it. Cultural and linguistic competence are provider skills. Keeping these distinct is essential on the exam. Question 42. A hospital system launches initiatives to ensure every patient, regardless of income, race, or geographic location, has a fair and just opportunity to achieve their highest possible level of health. Which concept is the hospital actively pursuing through these initiatives? Your options are A. Health equity, B. Health disparity, C. Biomedical model, D. Fee-for-service model. Take a second. Which answer would you pick? The correct answer is A. Health equity. A is correct because health equity means ensuring fair opportunities for everyone to achieve optimal health regardless of socio-economic status, race, or geographic location, which precisely describes the hospital system's mission of just and fair care access. B is wrong because health disparity describes measurable differences in health outcomes between populations, which is the problem being addressed rather than the goal of fair access and equitable opportunity the hospital system is actively pursuing. C is wrong because the biomedical model focuses on biological disease causes and clinical treatment, which is a clinical care philosophy rather than a mission to ensure fair and just opportunities for health across diverse populations. D is wrong because fee-for-service is a payment model based on service volume delivered, which is a reimbursement structure rather than a mission focused on fair and just opportunities for health across diverse socio-economic groups. Health equity is the goal of ensuring everyone has a fair and just opportunity to reach their highest level of health. It goes beyond simply measuring who is sick. It asks what a just system should actively do to close those gaps. Equity is not the same as equality. Equality gives everyone the same thing, while equity recognizes that people start from different places and may need different levels of support to reach the same opportunity. The mechanism of health equity is targeted fairness, identifying who faces the most obstacles and directing greater resources toward removing them. This means unequal inputs are sometimes necessary to produce a fair outcome. Health equity is frequently confused with three related concepts. A health disparity is the problem equity aims to solve. The biomedical model focuses on biology, not social fairness. Fee-for-service is simply a payment structure. None of these capture the aspiration of just opportunity. When an exam stem uses language like fair and just opportunity, regardless of income or race, or highest level of health for all groups, the concept being described is health equity, the pursuit of justice and health opportunity. Question 43. A clinic trains its staff to understand different cultural values and health beliefs, respect religious practices affecting treatment choices, and develop care plans that align with each patient's cultural background and traditions. Which capability are they actively building through this training? Your options are A. Linguistic competence, B. Health equity, C. Organizational behavior, D. Cultural competence. Before I reveal it, which one do you think is right? The correct answer is D. Cultural competence. D is correct because cultural competence is the ability to provide care that respects cultural differences and aligns treatment with patient values and beliefs, which precisely describes the capability the clinic is developing through staff training programs. A is wrong because linguistic competence refers specifically to effective communication across language differences, while cultural competence encompasses the broader understanding of values, beliefs, religious practices, and traditions that shape treatment preferences and meaningful patient care. B is wrong because health equity is the goal of fair opportunities for optimal health across populations, which is a systemic outcome rather than the specific provider capability to understand and respect individual cultural beliefs and practices. C is wrong because organizational behavior is the study of how individuals and groups interact within organizations, which is an academic field rather than a clinical capability for respecting patient cultural values, beliefs, and treatment preferences. Cultural competence is a provider capability, the ability to deliver care that respects and responds to patients' cultural values, beliefs, and practices. It emerged as healthcare confronted increasingly diverse populations whose health beliefs didn't fit mainstream medicine's assumptions. The core mechanism is understanding plus adaptation. The provider learns about the patient's cultural framework, their values, religious practices, and health beliefs, and then adjusts communication and care plans to fit within that framework. In practice, this might mean accommodating dietary laws, respecting beliefs about family involvement in medical decisions, or recognizing how a culture views a particular treatment. The provider meets the patient within the patient's own framework. The key distinction exam writers test is breadth. Cultural competence covers the whole landscape of values, traditions, and religious practices. Linguistic competence is the narrowest skill of communicating across languages. Health equity is the systemic goal of fair health outcomes. These are related but distinct concepts. When a scenario describes providers trained to understand cultural values, respect religious practices, and tailor care plans to patients' backgrounds, that is cultural competence. The signal words are cultural values, health beliefs, religious practices, and tailoring care, not simply translation or language access. Question 44. A hospital hires bilingual staff, contracts professional medical interpreters, and translates patient education materials into multiple languages so providers can communicate effectively with patients who speak different primary languages. Which capability is the hospital actively developing through these specific efforts? Your options are A. Cultural competence, B. Health equity, C. Linguistic competence, D. Patient-centered care. What's your answer? Commit to one before I continue. The correct answer is C. Linguistic competence. C is correct because linguistic competence is the ability of providers to communicate effectively with diverse patient populations across language differences, which precisely describes the hospital's investments in bilingual staff, interpreters, and multilingual patient education materials. A is wrong because cultural competence encompasses broader understanding of values, beliefs, and traditions affecting care, while linguistic competence specifically addresses the language communication capabilities the hospital is developing through interpreters and translated patient materials. B is wrong because health equity is the broader goal of ensuring fair opportunities for optimal health across populations, rather than the specific language communication capability the hospital is developing through interpreters, bilingual staff, and translations. D is wrong because patient-centered care prioritizes individual preferences and shared decision-making broadly, rather than specifically addressing the language communication capability the hospital is building through bilingual staff, medical interpreters, and multilingual education material translations. Linguistic competence is a healthcare organization's specific capability to communicate effectively across language differences. Unlike cultural competence, which addresses values and beliefs broadly, linguistic competence zeroes in on one precise challenge: language itself. Language barriers directly endanger care. A patient who cannot understand a diagnosis, a medication instruction, or a consent form cannot participate safely in their own treatment. Federal civil rights guidance reinforced that meaningful language access is a requirement, not an optional accommodation. Linguistic competence shows up as bilingual staff, trained professional medical interpreters, and patient materials translated into the languages a community speaks. Each of these investments targets the language barrier directly, ensuring patients can understand their providers and be understood in return. Exam writers test whether you can distinguish linguistic competence from related ideas. Cultural competence is broader, covering values and beliefs. Health equity targets systemic fairness. Patient-centered care involves patients in decisions. Linguistic competence is the narrow, specific capability to communicate across language differences. When a scenario describes bilingual staff, professional interpreters, or translated materials, the concept being identified is linguistic competence. Signal words include interpreters, bilingual staff, translation, and primary language. If the focus is on overcoming language barriers, that is your answer. Question 45. A community health study finds that patient outcomes are significantly shaped by factors like income, education level, housing stability, access to nutritious food, and neighborhood environment beyond clinical treatment itself. Which concept captures these non-medical drivers of health outcomes? Your options are A. Social determinants of health, B. Cultural competence, C. Biomedical factors, D. Linguistic barriers. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Social determinants of health. A is correct because social determinants of health are factors like income, education, housing, food access, and environment that shape health outcomes beyond clinical care, which precisely describes the non-medical drivers identified in the community study. B is wrong because cultural competence refers to provider ability to deliver care respecting cultural differences, which is a clinical capability rather than a framework describing how income, education, and environment shape overall health outcomes broadly. C is wrong because biomedical factors focus on biological causes of disease within the clinical treatment model, which contrasts with the broader non-medical social and environmental drivers like income, housing, and education the community study identified. D is wrong because linguistic barriers refer specifically to language communication challenges between providers and patients, which is one narrow issue rather than the broader framework of income, education, housing, food, and environmental health determinants. Social determinants of health are the non-medical conditions in which people are born, grow, live, work, and age. These upstream forces shape health outcomes powerfully, often more than clinical care itself. The core determinants include income, education, housing stability, access to nutritious food, and neighborhood safety. Research shows these social and economic conditions can predict life expectancy better than a person's genetic code. A child raised with stable housing, safe streets, and reliable healthy food gains advantages that compound over a lifetime. The reverse is equally true. Poverty, food insecurity, and unsafe surroundings continuously erode health long before any clinical encounter. It's important to distinguish social determinants from related but different concepts. Cultural competence is a provider's skill. Biomedical factors are biological disease causes. Linguistic barriers are a narrow communication issue. Social determinants are the broad set of social and economic living conditions outside the medical system entirely. When a scenario describes income, education, housing, food access, or neighborhood environment shaping health beyond clinical care, that is the signature of social determinants of health, the quiet, continuous forces behind disease and longevity. Question 46. A hospital's leadership team gathers to identify their internal strengths and weaknesses alongside external opportunities and threats before finalizing next year's strategic plan. Which widely used strategic management tool is the leadership team applying during the structured planning exercise together? Your options are a pest analysis, B, balanced scorecard, C, competing values framework, D, SWOT analysis. Which would you go with? Lock it in before the reveal. The correct answer is D, SWOT analysis. D is correct because SWOT analysis identifies strengths, weaknesses, opportunities, and threats to aid strategic planning, which precisely matches the hospital leadership team's structured exercise of examining internal and external factors before finalizing their strategic plan. A is wrong because pest analysis assesses political, economic, social, and technological factors affecting organizations, which focuses exclusively on external environmental factors rather than combining internal strengths and weaknesses with external opportunities and threats. B is wrong because the balanced scorecard evaluates financial and non-financial performance, including patient satisfaction and efficiency, which is a performance measurement tool rather than a strategic planning analysis of internal and external factors together. C is wrong because the competing values framework assesses organizational culture across 4 quadrants balancing adaptability and control, which evaluates culture rather than providing the internal, external strategic analysis the leadership team is currently conducting. SWOT analysis is a strategic planning tool that gives leaders a structured snapshot of their organization before setting strategy. What makes it distinctive is the pairing of an internal look with an external one, both perspectives on a single page. The tool is a 4-part inventory. Strengths and weaknesses look inward at the organization itself, while opportunities and threats look outward at the environment, naming all 4 guides where to build, fix, pursue, and defend. Think of SWOT as 2 intersecting lenses. The internal lens captures what the organization controls, its capabilities and gaps. The external lens captures what the environment presents, openings and dangers. Together they form one complete strategic picture. SWOT is commonly confused with pest analysis, the balanced scorecard, and the competing values framework. Pest looks only outward. The balanced scorecard tracks performance. The competing values framework maps culture. Only SWOT pairs internal strengths and weaknesses with external opportunities and threats in a single assessment. When a scenario describes leaders assessing internal strengths and weaknesses alongside external opportunities and threats before finalizing a plan. That is SWOT. The tell is always that both the inside and the outside of the organization are assessed together. Question 47. A health system strategist examines how upcoming political regulations, economic trends in insurance reimbursement, shifting social preferences among patients, and emerging technological capabilities will affect the organization's future direction. Which strategic analysis framework is she systematically applying here today? Your options are A. SWOT analysis, B. Balanced scorecard, C. Pest analysis, D. Competing values framework. Don't overthink it. Which one feels right? The correct answer is C. Pest analysis. C is correct because pest analysis assesses political, economic, social, and technological factors affecting organizations, which precisely matches the health system strategist's systematic examination of regulations, reimbursement trends, patient preferences, and emerging technologies affecting the future. A is wrong because SWOT analysis combines internal strengths and weaknesses with external opportunities and threats, which includes internal factors rather than focusing exclusively on the 4 external environmental factors the strategist is systematically examining here. B is wrong because the balanced scorecard assesses organizational performance across financial and non-financial metrics like patient satisfaction, which is a performance measurement tool rather than an environmental analysis of political, economic, social, and technological factors. D is wrong because the competing values framework evaluates organizational culture across quadrants balancing adaptability and control, which is a culture assessment tool rather than an external environmental analysis of political, economic, social, and technological forces. Pest analysis is a strategic tool that looks entirely outward, scanning the broad external environment that surrounds an organization. Unlike tools that examine what's happening inside, PEST maps the large-scale forces shaping an organization's future from the outside. The tool organizes the external environment into 4 categories: political factors like regulations and legislation, economic factors like reimbursement trends, social factors like demographics and patient preferences, and technological factors like emerging digital capabilities. Think of the organization sitting inside an environment it cannot control. Each of the 4 pest forces exists in the wider world, and leaders must scan all 4 systematically to anticipate what's coming rather than be caught off guard. The critical distinction exam writers test is that pest is exclusively external. SWOT mixes internal and external factors. The balanced scorecard tracks performance metrics, and the competing values framework examines culture. If every factor in a scenario is external and broad, the tool is pest. When a scenario describes a strategist examining political, economic, social, and technological forces all drawn from outside the organization, that systematic external scan is pest analysis. Question 48. A hospital CEO uses a structured dashboard to evaluate organizational performance across financial metrics, patient satisfaction, internal process efficiency, and learning and growth indicators together on one display. Which strategic management tool is the CEO actively using to monitor performance? Your options are A. SWOT analysis, B. Balanced scorecard, C. Pest analysis, D. Fishbone diagram. Got a guess? Lock it in. The correct answer is B. Balanced scorecard. B is correct because the balanced scorecard assesses both financial and non-financial performance, including patient satisfaction, process efficiency, and growth indicators on a single dashboard, which precisely matches the tool the hospital CEO is using. A is wrong because SWOT analysis identifies internal strengths and weaknesses, along with external opportunities and threats for strategic planning, rather than providing a multi-perspective performance dashboard covering financial, patient, process, and learning indicators together. C is wrong because PEST analysis examines political, economic, social, and technological external factors affecting organizations, which is an environmental scanning tool rather than a performance measurement dashboard combining financial and non-financial organizational metrics together. D is wrong because a fishbone diagram is a root cause analysis tool that identifies potential causes of specific problems, which is a quality improvement technique rather than a multi-perspective performance dashboard for organizational monitoring. The Balanced Scorecard is a strategic performance management tool designed to give leaders a rounded view of how their organization is actually doing, not just financially, but across multiple dimensions at once. The tool measures performance across 4 perspectives: financial, customer or patient, internal process, and learning and growth. Displayed together on one dashboard, leaders can see whether gains in one area come at the expense of another. Robert Kaplan and David Norton introduced the Balanced Scorecard in the early 1990s, precisely because financial numbers alone look backward. Leaders need measures that together predict future organizational health, not just past profit. The Balanced Scorecard is often confused with SWOT, PEST, and the fishbone diagram. SWOT assesses strengths and weaknesses for planning. PEST scans external forces. The fishbone traces root causes. Only the Balanced Scorecard is a multi-perspective performance dashboard. When a scenario describes a leader simultaneously tracking financial metrics, patient satisfaction, internal processes, and learning and growth on one display, that multi-perspective performance tool is always the Balanced Scorecard. Question 49. A hospital executive coordinates overall organizational direction at the top, competitive positioning of individual service lines in the middle, and specific departmental execution at the operational level. Which 3 levels of strategy does this hierarchical approach represent in healthcare? Your options are A. Corporate business functional levels, B. Planning, organizing, controlling levels, C. Political, economic, social levels, D. Forming, norming, performing levels. Which one is it? Pause the video if you need more time. The correct answer is A. Corporate business functional levels. A is correct because corporate, business, and functional levels represent the 3 strategy levels in healthcare, covering overall direction, competitive positioning of service lines, and operational execution, which precisely matches the executive's hierarchical approach described. B is wrong because planning, organizing, and controlling are 3 core management functions rather than strategy levels. So they describe operational management activities rather than the hierarchical corporate business functional strategy structure the executive is coordinating across. C is wrong because political, economic, and social factors are 3 components in PEST analysis for external environmental scanning, rather than hierarchical strategy levels that structure decision-making across corporate, business, and functional tiers of the organization. D is wrong because forming, norming, and performing are 3 stages in Tuckman's group development model describing team maturity, rather than the hierarchical strategy levels organizing decisions across corporate direction, competitive positioning, and functional execution. Large healthcare organizations make strategic decisions at very different altitudes. To keep things from collapsing into muddle, strategy is formally divided into 3 distinct levels, each with its own scope and purpose. At the top, corporate strategy sets the overall organizational direction, which markets to enter, which services to offer, how to allocate resources, Business strategy sits in the middle, positioning individual service lines to compete. Functional strategy operates within specific departments, turning higher level intent into day-to-day execution. The three levels form a cascade. Corporate direction sets the context for business level positioning, which in turn sets the context for functional execution. Each level serves the one above it, keeping grand direction connected to ground level action without collapsing them into one. Exam writers love to swap in lookalike triads. Planning, organizing, and controlling are management functions, not strategy levels. Political, economic, and social are pest scanning factors. Forming, norming, and performing are Tuckman's team development stages. None of these is the corporate business and functional hierarchy. When a STEM describes decisions organized from broad organizational direction down through service line positioning to departmental execution, it is pointing at the three levels of strategy. Match the decision to its altitude, either corporate, business, or functional, and you have the concept locked. Question 50. A health system administrator continuously monitors emerging regulations, competitor activities, demographic shifts, and market trends to help the organization adapt its strategy and anticipate external changes. Which strategic management activity is the administrator systematically performing here on an ongoing basis? Your options are A. Performance management, B. Talent acquisition, C. Environmental scanning, D. Controlling function. Take a second. Which answer would you pick? The correct answer is C. Environmental scanning. C is correct because environmental scanning involves monitoring external factors like regulations, competitor activities, demographics, and market trends to help organizations adapt, which precisely matches the administrator's ongoing systematic activity of tracking these external changes. K is wrong because performance management uses balanced scorecards and dashboards to monitor internal organizational performance, rather than continuously scanning external factors like regulations, competitor moves, demographic shifts, and market trends affecting future strategy. B is wrong because talent acquisition focuses on attracting and retaining skilled healthcare professionals to enhance service delivery, which is a workforce-specific activity rather than systematic monitoring of regulations, competitors, demographics, and market trends externally. D is wrong because the controlling function monitors internal performance against standards and takes corrective action within the organization, rather than systematically scanning external factors like regulations, competitor activities, demographic shifts, and broader market trends. Environmental scanning is the ongoing strategic habit of monitoring forces outside the organization, so leaders can anticipate change rather than react to it. The key word is ongoing. This is a continuous practice, not a one-time study. Leaders systematically watch 5 external domains: the regulatory, competitive, demographic, market, and technological landscape. Intelligence gathered across these areas feeds directly into strategic planning, prompting adaptation and warning of emerging threats or openings. The mechanism is a continuous loop. Leaders monitor external signals, interpret their strategic implications, and feed that intelligence into planning. The organization stays oriented by keeping this loop running at all times. Exam writers test whether you can distinguish environmental scanning from 3 related concepts. Controlling and performance management both look inward at results against standards. Talent acquisition focuses on staffing. Environmental scanning alone looks outward, continuously tracking external forces to guide strategy. Whenever a scenario describes continuous tracking of outside forces, I'd say it's regulations, competitors, demographics, market trends, to help an organization adapt and stay ahead. That is environmental scanning, It looks outward so the organization is never caught off guard.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.